Up next, Deepak Bhatt is joined by Dr. David Cohen, professor of medicine at the University of Missouri, Kansas City School of Medicine. They cover the conundrum of cost-effective but unaffordable care, the plight of new high-tech interventional therapies.
How can we continue to innovate in cardiology and afford it? And I've got to say this is a very practical issue because it's come up even locally in Boston with respect to left atrial appendage closure. How can we possibly afford doing it? There's data supporting its use, at least in some situations, but it's a very expensive device. And I guess from a hospital's perspective, more important than that societal cost is the fact that the reimbursement isn't sufficient for the actual cost that the hospital is seeing. So how are we going to deal with these issues?
I mean, you raise a number of challenges, and I think the challenges do exist both on the hospital level, where we all, for the most part, work these days, but also on the societal level, and they intersect. At the hospital level, at some level, it's simpler. There are two solutions, I think. One is lobbying for securing adequate reimbursement for technologies that are valuable. And what valuable is a societal or a political judgment at some level. The second is, hospitals like the one that you're in, I believe, increasingly are getting into the insurance business. When you're the hospital, but you're also the insurance company, like a Geisinger or like a Kaiser, you can make decisions that take into account a much longer term view, where the long-term benefits are meaningful as well. At a hospital that's reimbursed at a fee-for-service level, of course, that's a non-starter. But increasingly, that's as we start to get into more accountable care organizations or simply large hospital systems developing their own insurance products, that will be, I think, occur. So I think that one of those two is the only way you can potentially do a technology like the Watchman at a hospital level.
Part of that explanation, and it sort of makes sense to me, the differences, of course, between fee-for-service care and accountable care. But what about somebody that is really high cost, and that high cost intervention, it's not that it keeps them out of the hospital, it keeps them alive. I mean, from a purely economic sense, even in that ACCEL model, wouldn't it just be cheaper to let that really sick, high consumer of healthcare costs die instead of keeping them alive?
If cost saving is the object, delivering less care is almost always going to be the right answer. But of course, that sort of defeats the purpose of healthcare.
Yes, nobody's going to say 50-year-old, let him die. But,
right.
An 89-year-old, there it's a little bit different, right?
Right. The answer there is we have to have some standards as to what can we afford to spend to extend a life, to save a life, to improve quality of life for those things. And there are these standards in the field of public health and cost effectiveness analysis that allowed us to at least make those judgments. I wanted to kind of at least push on three things that I think are relevant here when thinking about technology and things that we're going to develop. The first one, what we've touched on already, which is it's important to recognize that cost saving and cost effective are very different. And if we only did things in medicine that were cost saving, we would do very, very little.
That's right. The interview would be over right now.
Yeah, exactly. There aren't many things. Even the things that, like preventive medicine is among the least cost-saving things that's out there. It's good because you intervene very early, but you have to treat a lot of patients with whatever preventive therapy it is, whether it's cholesterol lowering, whether it's breast cancer screening, any of those sorts of things. You apply them to so many patients. There are very, very few preventive interventions that are cost-saving. So it's important to keep that in mind. What's also important to keep in mind, though, is how good of a deal healthcare actually is if you look at life-saving interventions. There was a study, which I often cite in some of my lectures, by a woman named Tammy Tengs, who was at the Harvard School of Public Health when she published this, that compared the cost-effectiveness of treatments in different areas: healthcare, injury prevention, public health. Looked at them in a standard way using cost per quality adjusted year of life gained. Published, I think, in the New England Journal or in JAMA, I can't remember which. The conclusion of the study was that healthcare was by far the best bargain, that the average cost effectiveness ratio of things that were looked at in healthcare were on the order of $40,000 or $50,000 per year of life gained, whereas in injury prevention it was on the order of $80,000, and in public health, things like cancer prevention or environmental policies, millions of dollars per year of life gained. And so that I think it's important to keep in mind that yes, healthcare is a big part of our budget, but it actually is a very, very good way to spend money.
That's an important point. People talk about things like airbags, everyone's got one, but the cost effectiveness is really pretty low.
Right, there's way worse things than airbags that are out there. So that's important to keep in mind. The second is we do have to, I think, keep a very long-term perspective on technologies. And again, the one you cited earlier, left atrial appendage occlusion, is a perfect example. Up front, that's a very expensive treatment because it's a device, it's a hospital stay, it's a technically sophisticated procedure as compared to prescribing warfarin or a NOAC. But over the long run, there are several simulation studies that suggest that certainly for patients who can't take anticoagulants, it could be very, very cost effective, if not cost saving.
But they're
because of
not
the
well
stroke.
studied in that group, of course.
Right. No, I agree. I mean, there's some small studies out of Europe that are the basis for those
Sure.
comparisons. But even compared against, if we accept the results of the Watchman trials as being valid, the stroke prevention, the intracranial bleed prevention, all of those sorts of things, the avoidance of the need for monitoring, or NOACs, which are pretty expensive on an annual basis these days, it may not pay for itself, but it's very cost effective within 5 to 7 years. So it is a long run. It's good. And again, another example of that is something like TAVR, where if you look at it in the short term, it's just very expensive. If you look at it in the long term, it's still very expensive, but it extends life by a considerable amount and good quality of life for many of these patients.
Well, TAVR is a bit easier because of both of the reasons you cited. In the right patients, there's a mortality benefit, and it's hard to argue against that regardless of the cost implications. And there's a quality of life improvement that's huge and obvious.
Right.
But it's a little bit trickier, I think, with left atrial appendage occlusion, where yes, there's a reduction in stroke, but the comparators weren't NOACs. The patients in most of the pivotal trials actually got antithrombotic therapy and were candidates for it, but we're talking about using it in patients that aren't. There's a bit more extrapolation that goes on. But I get what you're saying.
Yeah.
But from a hospitalist perspective, and I'm not supporting this viewpoint, actually, I'm opposed to it, but the reality is that hospitals are going to say, in fact, they are saying, how can we afford to do this because we're going to lose money on each procedure.
Yeah, and you can't make it up in volume. You just lose more. TAVR in many centers that are in locations like mine, TAVR is the same way. Again, the reimbursement, we could spend a whole other topic talking about how the inequities in the reimbursement system for high-cost procedures in the United States. I wanted to make one more point, though, which is a lot of times... Yeah, the third point I wanted to make is that a lot of times it's not possible to predict, using our clinical trials or even intuition, what the true impact of a transformative technology would be. And I think Watchman could be something like that. TAVR, I think, is for sure something like that. Drug-eluting stents were. And the example I have actually comes from drug-eluting stents. So if you recall, about a decade ago when drug-eluting stents were first introduced in the United States, people worried a lot about the cost of them because they cost $3,000 a piece at the time.
Right.
And we did some economic analyses that suggested that if you used them in high-risk patients for restenosis, they weren't cost-saving, but they were, reasonably cost-effective, and that was part of the argument that helped Medicare, I think, believe that it was appropriate to pay for them. We did a follow-up study to that, which was not a trial. It was an observational study. It was a time series, and we asked the question: what happened to coronary revascularization in the United States before and after the introduction of drug-eluting stents? So we compared all the Medicare patients undergoing coronary revascularization by PCI or CABG. I think it was in 2000, 2001, before drug-eluting stents were approved, and then 2004, 2005. And we followed them for 2 years, these full cohorts, population cohorts. And what we saw was fascinating. First of all, we saw a shift in treatment patterns. So whereas in the earlier time period, 2/3 of patients were getting PCI, 1/3 were getting bypass surgery. In the later time period, it had shifted, and now there were 3/4 of patients were getting PCI, 1/4 were getting bypass surgery, a fairly substantial shift in the mix. In addition, the outcomes were better in terms of there was no difference in mortality, but the number of repeat revascularizations because of the introduction of drug-eluting stents was less. And what happened as a result of that, if you looked at actual spending per patient by Medicare for coronary revascularization and subsequent cardiac-related care, it went down. You would not have predicted that from the clinical trials because it was not due to just substituting drug-eluting for bare metal stents. It was due to a shift in the way the patients were being treated. Now, there was one little kicker to it, which I always hesitate to mention, which is that even though the cost per patient went down by, I think it was 6 or 7%, the use went up by 11%. So the net to the healthcare system was actually a little bit positive. But it was a treatment pattern and an outcome that could not have been predicted because you just don't know as technologies are introduced exactly how they're going to shift things. And I think that is likely going to be the case for something like a TAVR. And it is likely going to be the case for something like left atrial appendage occlusion. There are going to be treatment patterns that are going to emerge that are going to have, they may be beneficial, they may not, it's hard to predict. But if experience is any bellwether here, I think it is likely that they're ultimately going to lead to some cost reductions in ways that we can't predict. So that may help.
Yeah, no, that's some really elegant work you've done. Before we wrap up, any final pearls of wisdom you want to share?
Well, I think the pearls of wisdom are that we all, as physicians, need to be responsible. And we need to understand some of these issues and try to help both the payers, the government, and hopefully the innovators to come up with technologies that are these revolutions that will allow us to achieve, hopefully, some long-term cost savings.
Excellent. Well, thank you so much. That's really very insightful.
Thanks very much, Deepak.